Welcome to AIOC 2020 Gurgaon. Today, our instruction course is on glaucoma research clinical trials. I would request our first speaker, Dr. Swaraj Bhattacharya, who is from Tinsukia, to please come up on stage and present his topic on what are clinical trials and its protocols. Thank you.
Good morning, everybody. At the onset, I'd like to offer my sincere thanks to Dr. Sudipta ma'am for including me in this forum. My topic, what are clinical trials and its protocol? The clinical trials are the research investigations in which the people volunteer to test new treatment or intervention as a means to prevent, detect, treat or manage various diseases or medical condition. Some investigations look at how people respond to a new intervention and what side effect might occur. There are diseases of two types. One is observational or the non-experimental, and second one is the experimental. In the observation group is case report, case series, cross-sectional, case control and cohort studies, whereas in experimental group it's randomized clinical trial called RCT. Here in the observation group, it observes both the exposure and the outcome, whereas in the experimental group, it is struck. बंद हो गया ना ये रीस्टार्ट दिखा रहा है ना very sorry for the technical heckle. So in the randomized clinical trial we have assigned the exposure and we observe the outcome. Now advantages of clinical trial, it often provides the strongest evidence in support of the cause-effect relationship, and it's a basis for the clinical and public health policy, minimize and eliminate bias and confounding. There are different elements, core element of the clinical trial. They include the research question, hypothesis, core design, study participants, recruitment, allocation, masking, treatment group, data, analytical issues, and interpretation of the result. Now first the research question is critical in the design of a trial. Type of question for assessing the efficacy of an intervention and effectiveness of an intervention. Now in the hypothesis, there are two types. One is comparative trial called superiority trial to demonstrate a new therapy is superior to the standard therapy in terms of the incident outcome, or the equivalence or the non-inferiority trial to demonstrate that a new therapy is no worse than the standard therapy in terms of the incident outcome. Basic type of designs are two. One is parallel and second is crossover. The study participants, this is the target population. Now this is the accessible population, for example diabetic group. Then these are the study sample in the yellow, volunteers who have responded. Ideal accessible population are of the high risk for the disease. They should be the candidates for the treatment and representative of the target population. Enrollment criteria, there are two types, inclusion and the exclusion. Inclusion criteria, the characteristics of the accessible population, whereas in exclusion criteria, consideration related to the adherence to the therapy, follow-up, safety and ethics. Different strategies of recruitment includes general mailing, target mailing, mass media, screening, physician referral, medical record review, internet, etc., etc. It begins with the design. The response rate is always lower than the expected. Required resources are more than the expected. Dedicated personnels are necessary. The recruitment period is often longer than the expected. Implement several strategies to identify the best source, prepare backup strategies and monitor the recruitment should be early, often and locally. Suppose we give an example of the recruitment funnel. How does it goes? Suppose we have invited around 4,774 mailed invitation. Out of this, 43% only responded. And after the initial mailing, 38% of this group, again they have responded. And out of that one, 323 randomized after second mailing. And ultimately, 297 persons were included in the study. So ultimately, 7% cumulative comes in the recruitment. In the allocation group, there are two types. One is a random and non-random. It may be stratified and blocked, and non-random may be haphazard or systematic. What is masking or blinding? Is a procedure in which one or more parties in the trial are kept unaware of which treatment arms participants have been assigned. Like in the single blind study, the participant doesn't know. In the double blind, the participant and the clinician observer doesn't know. In the triple blind, even the data analyzer doesn't know the treatment arms. In the treatment groups, there are two types. One is the active treatment group and the comparison group. Many candidates' treatment dose intensity are uncertain, whereas in the comparison group, there were placebo, active control group, and usual care by the physician. And in the active control, there is variation in the standard care, and efficacy is not tested in the usual care by the physician. Next is the data. Baseline data determines the eligibility, describe the study participant, define the subgroups, and address confounding. Secondly, there are measures of adherence, and outcome variable may be principal outcome or secondary outcome. In the analytical issues, there may be sample size, analytical approach, and intention to treat. And the analytical approach may be crude analysis or regression analysis. It depends on the outcome data. Continuous outcome variable, the t-test, when dichotomous or categorical data in the chi-square or logistic regression or Cox modeling, this comes under crude analysis. Whereas in regression analysis, the continuous outcome comes out to be linear regression, time to event like Cox proportional hazard, or dichotomous outcome like logistic regression. Interpretation of the results, there are two types, internal validity and external validity. Internal validity conclusions correctly describe what happens in the study, whereas in external validity, the degree to which the conclusion apply to the study population and other population. The clinical trial protocol. The trial protocol is a formal document that specifies how a clinical trial is to be conducted. The protocol serves as a scientific, administrative, and organizational project guideline that may be the basis of a contractual relationship between an investigator and a trial sponsor. It should have an objective, a statistical consideration, administrative structure of the trial, design, and the methodology. The protocol should clearly address the issues related to the study's conduct, setup, organization, monitoring, administrative responsibility, publication policies, timeline in the appropriate sector. Well-designed protocols are important for conducting clinical trials safely and in a cost-effective manner. The summary is approved protocol goes to the investigator selection, approval process, patient recruitment and participation, data entered and reviewed, statistical analysis, presentation and publication of the report, data file, and the registration obtained. And thank you so much for the patient hearing. The subject is so vast, we try to make it little short as far as possible. Thank you so much.
Next, I would like to call upon Dr. Swati Singh, who's from Center for Sight. She's a senior glaucoma specialist, and she is going to present on what are the participants' eligibility criteria. Dr. Swati.
Good morning, everyone. I'll be speaking on participant eligibility criteria as well as the informed consent. And actually, it's the informed consent that I have to cover in detail. Next. It's not. So, before starting the informed consent, first a brief historical background. It was the Nuremberg Code, the first international document on the ethics of medical research, which was formulated in 1947 during the Nuremberg trial in Germany, where the Nazi doctors who were accused of conducting horrifying experiments on the inmates of the concentration camps during the World War II. And this code established 10 ethical principles to safeguard the human rights and highlighted the essentiality of the voluntariness of the consent. The important things that came out of the Nuremberg Code were the voluntary informed consent and the right of the participant to withdraw at any time during the course of the study. Next comes the Declaration of Helsinki. The World Medical Association issued this in 1964, which emphasizes the centrality of the informed consent in medical research involving the human subjects. Finally, the Belmont Report, which was published in 1978. This provided an analytical framework to guide the resolution of ethical problems arising from research involving the human subjects. It was based on 3 principles: the beneficence, justice, and the respect for person. This third point, the respect for persons, actually includes the importance of safeguarding the rights of the participating persons and the informed consent procedure. So in India, we are following the good clinical practice guidelines for clinical research, and they are based on the considerations of WHO, ICH, US FDA, European GCP guidelines, and the ethical guidelines for biomedical research on human subjects issued by the Indian Council of Medical Research. This has 2 cardinal principles: the protection of the rights of human subjects and the authenticity of biomedical data generated. These guidelines are mandatory to be followed for carrying out all the biomedical research in India. So now the informed consent. What is an informed consent? A consent which is given by a competent individual without being subjected to any undue force, influence, or intimidation, who is willing to participate in a clinical trial after being informed about the study and having understood all the aspects of the study, is called an informed consent. It is not a legal document, only a legal document, but a communication process between the investigator and the participant, which begins before starting the research and extends throughout the duration of the study. So it is a continuous process. There are 4 pillars of a valid informed consent. Number 1 is voluntariness, second is information disclosure, third is comprehension, and fourth is competence. So voluntariness, when the consent has been given by an individual without any force or influence to participate, is called a voluntary consent. The voluntariness may be affected by socio-psychological effects of prolonged illness, any religious and cultural influences on the subject, intellectual incapability to take a decision, and the vulnerable population. Second is the information disclosure. Providing the information that is necessary for the participant to take a decision is an essential element of a valid informed consent. All the information regarding the research procedure, including the purpose of the study, the interventions, any alternative treatments available, associated risks and benefits, the follow-up protocol, and the possible outcomes of the study, they should be detailed in the document in a simple language of 8th grade reading level. Number 3 is the comprehension. The participant must be able to comprehend the risks and benefits and the significance of participating in the research to make an informed decision. The illiterate, poor, and underprivileged population of developing countries may not be able to understand the process, and such subjects require a legally acceptable representative, or LAR. Competence is also the individual's decision-making ability, but unlike the comprehension, it denotes the participant's legal standing to make a healthcare decision. For example, a 16-year-old patient may be able to comprehend and decide for himself, but still remains incompetent from the legal point of view. So the informed consent document consists of the participant information sheet, or the PIS, and the informed consent form, or ICF. These have to be reviewed and approved by the ethics committee before enrollment of the participants. A good informed consent form should be readable and understandable for the subjects. It should have short and simple sentences and must provide full and accurate information and must abide by the regulatory guidelines. And it has also to be culturally sensitive, especially in a country like ours. There are some essential elements of informed consent form. It should clearly mention that it is a research, the purpose and the methods of research, the duration of study, frequency of contact, and the number of participants, the procedures and investigations to be performed during the course of the study, any foreseeable risks and discomforts adequately described, and whether the project involves more than minimal risk should be mentioned. The benefits to the participant, community, and medical profession as may be applicable. The freedom to participate and withdraw at any time without penalty or loss of benefits to which the participant is otherwise entitled, the identity of the research team and the contact persons with addresses and phone numbers, especially the contact details of the principal instructor and the co-instructor for research-related queries, and those of the chairperson or member secretary of the ethics committee or the institutional review board for appeal against the violations of ethical principles and human rights. Any new information about the disease, if becomes available during the course of the study, that may affect the individual participation should be shared. And a policy on compensation and free treatment for the research-related injury is mentioned. There are some additional elements of the There are some additional elements of the informed consent form, like alternative treatments if available, any test for genetics or HIV if to be done, the counseling should be done before, and any sharing of the data during the course of study, the sample, and if it has to be shared with others or for the publication, this should be mentioned, and the patient has the right to prevent the use of their samples and data at any time during the research. And the risk of discovery of biologically sensitive information and provisions to safeguard the confidentiality. So in a nutshell, the informed consent process starts with a discussion with willing subjects and the legally acceptable representative with the disclosure of the essential information. Ample time is provided to read and understand the information. Patient can ask as many questions as he wants about the different aspects of the research, and then they decide about participation. Once they give their consent for participation, the signature on the consent form by the participant and the representative and an impartial witness is sought. The subject is handed over a signed and dated copy of the form, the patient information sheet. But the process doesn't end here, and the sharing of new information and updating the consent document continues. A special note about informed consent in vulnerable groups. When recruiting patients who are vulnerable, their inclusion should be justified by the researchers and approved by the ethics committee. A legally acceptable representative is involved in decision making, and additional precautions have to be taken for protecting their rights and dignity and safety. Also, audiovisual recordings should be done in such cases. These are the vulnerable population: the children, pregnant women, terminally ill, the minorities, refugees, prisoners, etc. And consent in children requires, when the risk involved is less than minimal, or if there is direct benefit to the child, then only one parent can give the consent as per ICMR guidelines. And when the risk is more than minimal, then both the parents should need to give the consent. And there is something called assent in children who are 7 to 12 years of age and adolescents. Assent is the child's agreement to participate in the research, and the contents of the assent form have to be in accordance with child's development, maturity, and the cognitive status. Lastly, the waiver of the consent. The researcher may request for a waiver of the consent if the research involves less than minimal risk to participants, and waiver will not adversely affect the rights of the participants. This is applicable especially in conditions like emergencies and disasters, in public health studies and surveillance programs, and retrospective studies where the participants are de-identified and cannot be contacted. Finally, the eligibility criteria is studies protocol has guidelines for who can and who cannot participate in the study. Enrolling the patients with similar characteristics ensures that the results are due to what is being studied and not confounded by other factors. These criteria differ from study to study and help the researchers achieve the accurate results. The exclusion criteria make sure that the people who could get worse by participating in the study are not exposed to the risk. Just thank you very much.
Thank you, Dr. Swati. Next, we would like to call upon Dr. Tathagata De to please present his talk on what is an institutional review board and clinical trial sponsor.
Good morning, everybody. First, I give my sincere thanks to Dr. Sudipta Ghosh for including me this instruction course. So my topic is what is an institutional review board and a clinical trial sponsor. Institutional review board is an administrative body established to protect the rights and welfare of the humans subject required to participate in a research study conducted under the auspices of the institution. The role of the IRB or Institutional Review Board is to ensure the protection of the human participants in a research subject. The role of the IRB or the Institutional Review Board is to ensure the protection of the human participant in a research study. Any institution that received the federal rounding to conduct research with human participant is required to establish an IRB and the review of the approved studies prior to collection of the research data. Primary purpose of such review is to ensure the protection of the rights and welfare of the human subjects. Institutions mean any public or private entity for agency, including the federal, state, and other agencies, including hospitals, universities, private medical clinics, and so forth. Regulatory responsible to the IRB are found to follow the regulations, organization, and personnel, to follow written procedure, including those for conducting the initial and continuing review of research and reporting those findings to the investigators, to determine which projects require review more often than annually, ensure prompt reporting to the IRB of the changes in the research, ensuring that the changes are not implemented before IRB review, except where necessary to eliminate apparent immediate hazards of human subjects, promptly report to the IRB institution and the federal ENIP. Unanticipated problems involving the reasons of the human subjects. Any instance of serious or continuing non-compliance with the regulations or IRB requirements. Any suspensions or termination of the IRB approval. Review proposed research at conference meeting with a majority members present, including at least one member whose primary concerns are non-scientific. Require that information given to the subjects as part of informed consent meets the regulations. Notify investigators in writings of its decision to approve or disapprove the proposed research or of any modifications required to secure the approval. Now the clinical trial sponsor. A clinical trial sponsor is defined as a person who takes responsibility for and initiate a clinical investigation. The sponsor may be an individual or a pharmaceutical company. Sponsors are responsible for selecting the qualified investigators, providing the investigators with the information that need to conduct an investigations properly, ensuring proper monitoring of the investigation, ensuring that the investigation is conducted in accordance with the jail investigation plan and protocols contained in the IND, ensuring compliance with labeling, reporting, and record-keeping requirements, refraining from the engaging in promotional activities and other prohibited activities such as the commercialization and investigational medical device, ensuring that the clinical studies conducted in accordance with the good clinical practice. Thank you.
Nazreen? Thank you, Dr. Tathagata. I would request Dr. Prerna to please come and speak on her topic. Her topic is, what is the outcome of a clinical trial after completion and what difference does it make?
Good morning, everyone. First of all, I'd like to say thank you to Dr. Sudipta for including me in this IC. So I'll start with what are the outcomes of clinical trial after completion and what difference does it make? So what is an outcome? Outcome measures an endpoint. It is effect measure which is used to assess the effect. It can be both positive and negative. It can be an intervention or a treatment. So measures can often be quantified using effect size. Outcome measures can be patient reported, laboratory tests like blood works, medical examination. They should be relevant to the target of the intervention be it a single person or a target population. So depending on the design of the trial, outcome measures can be primary outcomes or secondary outcomes. Primary outcomes, in which case the trial is designed around finding the adequate study size. Secondary or tertiary outcomes are the outcome measures which are added after the design of the study is finalized. For example, when the data has already been collected. A study can have multiple primary outcome measures. So outcome measures used in trials should consider relevant to the target of the study. In clinical trials, such measure of direct importance can be survival, quality of life, morbidity, suffering, functional impairment, or change in the symptoms. Outcome measure can also be divided as clinical endpoints or surrogate endpoints. Clinical endpoints are directly relevant to the target or are directly related to the goal of intervention. Surrogate endpoints which are indirectly related to the target. So like death from a cardiovascular disease is the clinical endpoint, but high blood pressure which causes cardiovascular disease is a surrogate endpoint. There are composite measures or combined measures. Rationale is that combining different outcome measures gives greater statistical power. However, composite measures should be used with care, particularly when surrogate endpoints are included. So what are trial endpoints? The measure chosen to assess the impact of interventions are called outcome measures of a trial. Such measures should be defined at the time when the trial is designed and should be specified in detail in the study protocol. The outcome should be compared between those in different intervention groups and should be measured in consistent way during the course of trial in different groups. Clear definitions are also necessary so the measures can be replicated in other trials and meaningful comparisons can be made between the trials. So failure to pay sufficient attention to precise definition of a primary outcome measure at the start of the trial may lead to confusion in interpreting the result and can even invalidate the results. So primary outcomes are the most important outcomes, the ones that determine the design and study size. They represent the main reason why the trial is being conducted. However, more than one primary outcome may be selected in some trial providing the design and sample size allow it, and if measuring them in the study does not subsequently adds to the cost or complicate the design or conduct of a trial. Secondary and tertiary outcomes, trials often have additional important outcome, but these are not usually used to determine the trial size or sample size. These outcomes may not be statistically conclusive since the trial may not have been designed with the power to evaluate them, but they can be very useful to generate further hypotheses and guide future trials. So because of their importance in justifying future studies, these additional outcomes also need a careful definition and measurement should be fully specified in the protocol, since extra resources are often needed to measure and evaluate them as well. Other variables which are not study outcomes are age, gender, education, socioeconomic status, nutritional status. These variables also need to be defined and considered at the beginning of the study, so they may be included in any pilot investigation. Factors influencing the choice of outcome measures are what are the relevance, feasibility, acceptability, and opportunity to add other studies. Relevance is interventions are generally designed to reduce the disease or promote health. So outcome measure chosen should reflect that these objectives are fully possible. Feasibility, to be successful, a trial must be designed to have an achievable objective. A trial in which mortality is an endpoint and too large to be successfully completed may not be of much value, and there must often be a compromise between relevance and feasibility. Acceptability of the measurement of an outcome variable to the study population is critical to the successful conduct of trial. If the method of measuring the outcome involves pain or inconvenience to the participants and cause long time duration, then it will not be acceptable. Opportunities for add-on studies. Some trials offer opportunity to measure outcomes and they are not directly related to the objectives of the original study itself. These opportunities can be exploited by the researchers to answer the questions with minimal adding funding. So the variability and quality control of outcome measures are reproducibility, the extent to which different observers will make the same diagnosis and assessment on participants and to which observers have consistent in their classification between participants may have an important influence on the result of trial. Clearly, it is desirable to choose outcome measures for which there is substantial reproducibility and agreement among the observer with respect to the classification of participants. Sensitivity and specificity. The choice of the appropriate definition of a case in a field trial will be influenced by sensitivity and specificity associated with diagnostic criteria. Sensitivity is defined as the proportion of true cases that are classified as case in the study. Specificity is the proportion of non-cases that are classified as non-case in the study. So low sensitivity is associated with reduction in measures of incidence of disease. In statistical term, it reduces the power of the study. Bias. The most powerful way to minimize bias is to have a double-blind randomized trial. If these two aspects are built in the trial, an effect on the intervention is not likely to be observed and there is no true effect. There are some quality control issues. The sensitivity and specificity of diagnostic procedures employed should be monitored for the duration of the trial as they may change the study progress. It is important that the field staff is aware that they are being monitored. Sometimes they can go off rail and they have to be steered back for a good monitoring, and quality has to be maintained. The Hawthorne effect, the indirect effect known as Hawthorne effect, named after a study in 1930 in USA. It as works in which document the workers' behavior changes as the consequence of them being observed. So this effect reduces the power of study and may make it inconclusive. So there is no easy way to control it. If Hawthorne effect is expected, the sample size has to be increased to increase the statistical power. So there are few glaucoma studies which have an outcome which I think will be spoken by the next speakers. So this ocular hypertension treatment study, the primary outcome was the development of reproducible visual fields and reproducible optic disc deterioration. Early manifest glaucoma trial, the main outcome was defined by sustainable increase in field loss in 3 consecutive tests and computer-based analysis and optic disc changes. In collaborative normal glaucoma tension study, the main outcome was disease progression and visual field progression and disc progression. In European glaucoma prevention study, the main outcome was efficacy endpoints, visual field changes, optic disc changes, and safety endpoint was IOP more than 35 on 2 consecutive examinations. So I guess that is the outcome trial as the end game for a principal investigator. Thank you very much.
Thank you, Dr. Prerna. Excellent. I would like to call upon our next speaker, Dr. Nazning, to please speak on what are the types and phases of clinical trials. Eta?
Good morning, everyone. I'd like to thank Dr. Sudipta Ghosh Madam for including me in this instruction course. So I'll be talking on clinical trials, types and phases. So what is a clinical trial? A clinical trial is a prospective biomedical study of human subjects that is designed to answer specific questions about biomedical or behavioral interventions like drugs, treatment, devices, or new ways of using drugs, treatment, or devices. Or simply put, experiments and observations in clinical research which generate data on safety and efficacy are known as clinical trials. Some of the landmark clinical trials were the HOPE Heart Outcome Prevention Evaluation Study, the DASH trial, and the UKPDS trials. So coming to the types of trials, there are 2 main types of trials, observational and interventional. In the observational, investigators observe subjects and measure outcome, but they do not actively manage the study. In interventional study, there are 2 groups, one with intervention and one without intervention. The intervention can be drug, surgery, a medical device, or a diagnostic intervention. The interventional study, we know about the landmark AGIS, Advanced Glaucoma Intervention Study. So coming to the types of trials, the trials can be prevention trials, treatment trials, diagnostic trials, quality of life trials, compassionate trials, and epidemiological trials. So prevention trials, trials which are used to determine how to prevent occurrence of disease in disease-naive patients. This may include the use of vitamins, micronutrients, drugs, vaccines, etc. Treatment trial, we know about the landmark optic neuritis treatment trial. The diagnostic trials are trials which are undertaken to find better tests or procedures for diagnosing a particular disease. For example, MRI versus prostate-specific antigen in prostate cancer screening. Screening trials are trials where a screening, for example, a PSA is used to screen for prostate cancer. Compassionate trials are also known as expanded access trials, where a person who is likely to not survive a disease, a lethal disease, is given an investigational drug. The investigational drug must be under active clinical development. An example is imatinib, which is available as Gleevec, which is given for CML, myelodysplastic and myeloproliferative diseases. Adaptive clinical trials are clinical trials in which interim results are used to modify the trial as it proceeds. So the example is I-SPY 2, which used, which is an adaptive trial, and it identified 2 promising drugs in just 6 months. Quality of trials we know. So I'll be coming to the phases. So before we get a drug in our hand, like the newer drug, the ROCK inhibitors, a lot of research goes into it. So clinical trials are divided into phase 1, phase 2, phase 3 and phase 4. The clinical trials are experiments which are conducted in the lab or on animals. Phase 0 or phase 0.5 study, here a single microdose study, a dose of the drug is given in normal subjects, and the dose is typically 1/100th of the proposed therapeutic dose. Phase 1 is the first in-person trials, which is done on a small group of people or volunteers, typically 20 to 80. These volunteers can be healthy human volunteers or patient volunteers, where you test for cytotoxic drugs or other anti-cancer drugs. In most of these cases, you also have a placebo arm where no drug is given. You need to stop when there are serious adverse drug effects or there is major toxicity in human beings. So at the conclusion of phase 1, you should have sufficient data about the starting dose and the dose ranges to be used in phase 2, and whether that study should be continued or not. The importance of phase 1 can be understood from the Parexel Northwick Park disaster, where a drug called Parexel was given to 5 subjects who developed life-threatening disease. Phase 2 is to establish the efficacy of the drug. It is done in large group of people, like 100 to 300, and it is used to determine the safety and efficacy of the drug versus placebo. The ideal dose is found out, and also whether the decision is taken whether to proceed to phase 3 or not. Phase 3 is the final confirmation for the safety and the efficacy of the drug, and dosing schedule is also determined. Here the drug is tested on 1000 to 3000 people, and the drug controller DCGI approval is obtained. Phase 4 is the final phase, where the drug is released in the real world and it is used by hundreds and thousands and lakhs of people. However, surveillance as to the adverse drug effects is done. So to conclude, clinical trials are indispensable to study safety and effectiveness of drugs and devices. Success of clinical trials has resulted in tremendous advancement of medical science and benefit for patients. Thank you.
Exactly. Thank you, Dr. Nazneen. Next coming is Dr. Pawan. He's from Arvind Eye Hospital, a glaucoma specialist, and he's going to speak on what are the terms placebo, randomization, and blinded mean in clinical terms trials.
Good morning, everybody. I sincerely thank Dr. Sudipta Madam for giving me this great opportunity. And I'm going to talk about these terms called placebo, randomization, and blinding. So we keep often using these terms in our clinical trials. Just a brief presentation on what exactly these mean. So what exactly is placebo? So if you take that this as the active drug, a similar one which really looks like that but really does not do any effect on the body. So this we call it as a placebo. So this placebo is another we can call it as a dummy medicine, and here mostly the psychodynamic properties will act compared to pharmacodynamic properties, and those people who respond for the placebo are called placebo responders. So the results obtained by administering a placebo is called placebo effect, and it's more of a psychophysiologic effect. So what are the types of placebo effect? We have positive, which gives an improvement in the symptoms. We can call it as negative if there is a worsening of the symptoms. So there is one more term called nocebo. This is just opposite of placebo, where placebo we expect it to give a good results, whereas nocebo will give a negative results. So how do we do that? We just give a drug and we tell the patient that this can cause so many side effects, this can cause this and all that and all. So then the patient can have those symptoms because of the psychophysiological effect, or it can happen also because of loss of faith in medication or physician. So types of placebos, we have two types. One is inert or pure placebos, where the substances that have really no pharmacologic effect on the patients, whereas active or impure placebos, they have some pharmacologic effect but not related to the trial what we are intended to do. So there are many factors which influence the placebo response. This includes patient characteristics or a provider characteristics, appearance of the treatment characteristics, and environment relationships. So in clinical trials, researchers compare the results of experimental treatment versus placebo, and the placebo controlled trial is the gold standard for testing the efficacy of new treatments, and best evidence for new treatment come from randomized placebo controlled double blind studies. So when you know that double blind studies, we need to know what is blinding. So when a patient comes to, when a trial is happening and a patient is coming, so what we do is we do a procedure called blinding. It's a procedure where one or more parties in a trial are kept unaware of which treatment arms participants have been assigned to. So either the participant or the trial or the expert is not aware what treatment what patient is undergoing. So it is used to prevent conscious or unconscious bias in the clinical trial design and how it is carried out. This is important because bias can affect recruitment, allocation, care, attitudes, assessment. So that means like if a patient is coming with a narrow angle, so he should not know that which patient is going to go for a ACPA trial or just observation trial. The examiner should not undergo, so that we can, over a period of time, we can observe. So it is used to ensure the objectivity of the trial results. So there are potential sources of bias in a trial, like what patient is getting treated, or who is the clinical staff who is administering the treatment, or doctor who is assessing the treatment, or team interpreting the trial results. So to avoid all this bias, the blinded is introduced. So who and all can be blinded? The first thing is the participant himself is, if it is blinded, or even the clinician can also get blinded, or even the analyst can also be blinded. So depending on that, we classify that as unblinded or open label trial, or a single blinded or a single mass trial, or a double blind or double mass trial, and finally triple blind trial. So what is, to know what is unblinding the trials is a trial in which no blinding is used, and is all parties aware of what treatment is going on. This is called open label. So then comes single blinded trial, where only the participant is blinded, rest all the people will know what is happening. The next is double blinded trial is both the patient and the doctor are blinded for the treatment which is happening. Only the analyst will be knowing what is happening. So this is a best controlled trial design. It decreases chance of observational bias and should be used whenever possible. The third thing is a triple blinded trial, where the patients, clinicians, data collectors, outcome adjunctors, and data analysts are denied across the details of the group assignment. So nobody knows what exactly is happening, but the trial can be allocated as, suppose a medicine is happening, we can label it as A or B, but we don't know what is A, what is B. So the analyst is blinded as to which treatment is which, and it helps to avoid bias in the analysis of the results. So finally, in some part of research time, we may have to disclose what is actually happening. So this is called unblinding. Unblinding is the disclosure of the treatment to a participant or a study team. So when we know that the particular drug is causing some effect or some treatment is causing some problem, then it is our duty to unblind it and take over the necessary action. So sometimes in a crossover design also, the participant may only be unblinded for the most recent dose. So the last thing is the randomization. So randomization is a process by which allocation of subjects to treatment is done by chance, without the ability to predict who is in what group. That means a patient is coming, we just give a chance, who goes to what group, not because of certain characteristics. So we have two purposes of doing this. The primary purpose is to prevent bias in allocating subject to treatment group, and the secondary purpose is to achieve comparability between the two groups. So it is simple randomization, block randomization, stratified block randomization, dynamic random allocation. Simple randomization is randomization based on a single sequence of random assignment. The best method is to flip a coin. A patient comes, just flip a coin, heads goes to one group, tails goes to other group. So it can also be used as a computer generated sequence. The problem with simple randomization is it's simple, but sometimes in a small group it can cause unequal distribution of the two groups. So the next group is a block randomization, where you are going to take the people in a block. The block is designed to randomize subjects to group that results in equal sample sizes. It is used to ensure a balance in sample size across groups over time. So it is used for a small studies to maintain reasonably good balance among the groups. Suppose if there is a group A and group B, then A is intervention and B is control. We have to make sure that both the group gets equal number of participants. Then is a stratified block randomization. Suppose we have already made into 2-3 blocks. So in those blocks also we have another varieties, co-varieties, which can again affect our observations. Like suppose there is a group A, group B. In that group A, there are patients who are more than 65 years of age or less than 65 years of age, or another group where they are more of male or female. So we may know what is the particular treatment or what is the disease happening into the particular groups. So we may classify according to that also in that particular block. So that is called stratified block randomization. And the last thing is dynamic randomization. Dynamic randomization is initially the randomization will happen, and once the randomization keep on going on, so there is a dynamic factors which is going to happen, like certain varieties will take into consideration, and in between the next process what is happening, we'll use the covariates and we'll start allocating in a different way. So it is that it's not at the beginning of the study. When the study is happening, there is dynamic change and dynamic randomization is going to happen. Thank you.
Thank you, Dr. Pavan. And the last talk for this session is on ongoing clinical trials. No. Okay. So glaucoma research ongoing trials. Treatment versus treatment trials. Coming to the light, what is light? It is laser in glaucoma and ocular hypertensive study which was conducted in 2019. What was the objective of the study? It was to compare the eye drops versus selected laser trabeculoplasty as the first line of therapy for ocular hypertension and primary open angle glaucoma. The design, the first line of eye drops were prostaglandin analogs, second line were beta blockers, the third and fourth line were topical carbonic anhydrase inhibitors and alpha agonists. Coming to the primary outcome, they measured the quality of the light. The secondary outcomes were the visual acuity, the IOP, the cost, disease progression, and need for glaucoma surgery. The patient demographics and the ocular characteristics were similar between the two groups. If you can see in the results, the SLT group did much better compared to the eye drop group. The limitations of the study were it utilized a target-to-target design that does not provide clear IOP reduction parameters. So coming to the clinical pearls, the SLT is both clinically effective and cost-effective option for the first line of treatment for primary open angle and ocular hypertensive patients. It may spare patients eye drops and reduce the risk for future glaucoma surgery. Next coming up is the Ahmed versus the Bawal study, which was conducted from 2011. Here they compared the outcomes of patients undergoing the placement of the Ahmed versus the Bawal glaucoma drainage implants. Here the patients were randomized to receive either an Ahmed glaucoma valve drainage implant or a non-valve glaucoma drainage implant. The primary outcome as a surgical success was measured by 5 parameters that included the intraocular pressure, the medications, the adverse events, interventions, and visual acuity. Complete success in this study was defined as an IOP of 5 to 18 millimeter of mercury with a 20% reduction of IOP of all ocular hypertensive drops, and the failure was defined as any of the following: IOP less than 5 millimeter of mercury or greater than 18 millimeter of mercury. Coming to the results, we can see that the Bawal group did better, but vision-threatening complications were more seen in the Bawal group than in the Ahmed group. The limitations, the intraocular pressure was primary parameter determining success and was standardized at 5 to 80 millimeter of mercury, which does not take into account the individual patient goals. The predefined success parameters resulted in a few patients meeting criteria for the success. Furthermore, clinical progression of patients was not taken into account. The clinical pearls, although the results in the Bawal group was better, but there was significant vision-threatening complications in the Bawal group than compared to the Ahmed group. Coming to the TVT study, that is the tube versus trabeculectomy, which was started in 2005. Here the objective was to compare the safety and efficacy of trabeculectomy to tube shunt surgery in patients with previous intraocular surgery. Here they designed the patients and they were randomized. One group underwent the tube while the other group underwent the trabeculectomy. Coming to the results, after 3 months, both procedures produced sustained pressure reduction to the low teens throughout the 5-year duration of the study. The trabeculectomy had a higher long-term failure rate compared to the tube, whereas the trabeculectomy eyes with mitomycin C achieved better in early IUP control in the first 3 months and less use of adjunctive medical therapy in the first 2 years only. Limitations: patients with refractory type of glaucoma like neovascular glaucoma excluded. Mitomycin C was used for 4 minutes, which is much longer than most surgeons currently used, and this could be accounted for the high rate of hypotony in the trabeculectomy group. Coming to the treatment versus no treatment trials, the ocular hypertensive study, which was conducted in 2002, it had two major goals. The first one was to determine if early treatment of people who have increased intraocular pressure with topical ocular hypertension would prevent them from developing primary open-angle glaucoma, whereas the second goal of this study was to determine which people are more likely to develop glaucoma. Design not going into the further details, the diagnosis of glaucoma was made when patient developed a reproducible visual field defect or reproducible deterioration in the appearance of the optic disc. The results: the predictive factors found included increasing age, increasing intraocular pressure, decreased thickness of the cornea, and increased cup disc ratio. The ocular hypertensive patients are at a low risk of developing glaucoma, as low as 1 or 2% over 5 years, where the other groups are at a much higher risk at the rate of 25 to 35% over the 5 years. The main outcome measures: the primary outcome was development of the reproducible visual field abnormality or reproducible optic disc deterioration attributed to the primary open-angle glaucoma. Coming to the limitations, the study IUP goal was 20% reduction. There was no measure of the medication adherence, not population-based epidemiological study. Some risk factors underrepresented. There was high threshold for diagnosis of primary open-angle glaucoma, and the criteria for conversion of primary open-angle glaucoma adjusted during this study. So they concluded that the topical ocular hypotensive medication was effective in delaying or preventing the onset of primary open-angle glaucoma in individuals with limited IOP. The OHTS supports offering eye drop treatment to ocular hypertensive people and was studied carefully to see if the medications were safe or not. Next, coming to the European Glaucoma Preventing Study, which was in 2002. Here, the objective was to evaluate the efficacy of reduction of IOP by dorzolamide in preventing or delaying POAG in patients affected by ocular hypertension. The patients fulfilled a series of inclusion criteria, including eye intraocular pressure, 2 normal and reliable visual fields, and the normal optic disc. The main outcome measure here was the efficacy endpoints for visual field and optic disc changes, or both. And in the results, we saw that during the course of the study, the mean reduction of IOP in the dorzolamide group was 15% after 6 months and 22% after 5 years. Limitations of this study was there was a high dropout rate. Only one type of IOP lowering medication was evaluated, then the intraocular pressure difference reached between the two groups was small. The pearls for clinical practice: the same predictors for development of POAG in OHTS study and were the baseline older age, the higher intraocular pressure, the thinner central corneal thickness, vertical cup disc ratio, and higher Humphrey visual field pattern standard deviation. The EJPS study failed to detect the statistical difference between the chosen medical therapy and placebo, either in IOP lowering effects or in the rate of progression of POAG. Thank you for your patient hearing. With this, we end our instruction course on the glaucoma clinical trials. I would request all our speakers to please come on stage, and we'll have a group photograph.
I think we have a keynote address by Professor Will Morgan, or William Huxley Morgan. He is the Managing Director of Lyons Eye Institute, Center for Ophthalmology and Visual Sciences, University of Western Australia, and he is based in Perth. The Lyons Institute is actually a very well-known institute in the Southern Hemisphere, one of the largest research facility actually. And perhaps you don't know Bill Morgan, he is the inventor of Zen implant. So you are hearing Zen implant, you will be hearing more and more in coming days once it's introduced in India. But this is being used in Europe quite frequently, and also in Australia with very good results. And we have no other than Bill Morgan here to talk to us today. So we are really very grateful and very fortunate that you are here this morning. Thank you very much for coming over. I'm not sure what the title of your topic today would be, but I'll request you to please come to the podium and address. Thank you.
Can we go back to the first slide? Or, sorry. That's sort of halfway through the talk. I can plug my computer in. That's about the third slide. Oh, I know. Can I use my own computer?
Which port? Do one thing.
And some different ports here.
First, you have to like put it out there. That's fine. Give it to. I'm just Vijay. Yeah.
I think while Bill is setting up his laptop,
You can have HDMI as well.
Yeah, of course.
a little more about Bill. He is actually a very prolific researcher, and if
do
you
one
go
second.
back in pathophysiology of the
Yeah.
glaucoma genesis, the relationship with cross lamina fibrosa actually is his work, and which has been there now picked up by many other people. I think it's ready. So, Bill, thank you. Over to you.
Surinder, thank you very much for your kind introduction, and thank you for inviting me to speak here in India. It's such a lovely country, and I really enjoy coming to India. What you're seeing here is the very first human Zen. Well, we didn't call it Zen in those days, it was a cross-linked gelatin stent that we implanted back in 2007, and that followed about 10 years animal and design research work. And I just want to thank my collaborators, the main person being Professor Dao-Yi Yu, who was the brains and the engineer and the worker behind most of this work. And also to disclose the fact that I am one of the inventors of the Zen, so I do have a bias, you might say. So the original idea for microfistula or cross-linked gelatin surgery was to create a stent. So, for example, trabeculectomy is an operation in which you basically cut a channel into the eye, and it causes a lot of surgical trauma. The original idea that we had back in 1996 was to inject a channel rather than cut a channel, and so avoid most of the trauma associated with surgery in the likes of trabeculectomy. We wanted to inject a stent made out of a biologically compatible material, and cross-linked gelatin was the material that Professor Yu chose and spent quite some years refining the proportions in terms of cross-linking and drying, making it a material that was hard or rigid to start with, and then when it becomes moist, it goes soft and floppy like a vessel. So it becomes a soft vessel. So for example, with the glaucoma drainage devices, they're always rigid to some extent. So every time you blink your eye or rub your eye, you're going to induce a little bit of trauma by having that semi-rigid structure in the eye. Whereas we wanted something that would be flexible. And the other thing was to have an operation where we didn't have to cut the conjunctiva, but we could inject the stent ab interno, so across the anterior chamber, so avoid any conjunctival wound. So this is from our original patent, the US patent from 1997. This was some of the early design work where we initially started with beef collagen, lots of work initially refining the rigidity and mechanical characteristics, and then about 400 rabbit experiments and quite a few monkey experiments to look at the longevity and the effectiveness of the stent. The stent was injected through sclera, obviously through the trabecular meshwork, into the subconjunctival space, and then in those animal experiments we could look at the histology and check how much inflammatory reaction we were getting. And you'll see here from one of the rabbits that there's very little inflammatory reaction that was induced by the gelatin stent. So there was quite a long story to do with the commercialization and attracting a commercial partner to make a version that could be used in patients. So it's one thing having all the laboratory kit for an animal, but then when you want to use something on patients, it has to be sterile and also usable by the surgeon. So we began the first human trials back in 2007, and over the following 3 years, we modified the insertion device, and I'll show you some different examples of those. We also modified the gonioscopy and the way in which we hold the eye. So I'll just show you, if you have an eyeball here, like my fist, and you inject a stent or something into it, and you're pushing on the eye, just your force will tend to want to make the eye rotate. So then the area of interest, for example, the limbal region on the other side, goes out of view. So you need some way of fixating the eye which doesn't distort the eye too much. So this is pretty much where we ended up at in about 2010, towards the end of the first phase 1 and phase 2 trials. There's a special high refractive index gonio lens. We've made a special speculum with a little eye ring, or semi-eye ring, which you can stitch the eye to. And so as you go through and force the needle through the meshwork and sclera, there's no noticeable counter-rotation of the eye. And also it gives you a spare hand, and you can see the injection needle there. Now it's being withdrawn, and the stent is being delivered into the subconjunctival space. So that's a pretty typical operation. There's a high degree of control where you can see where you're going. Now this is some examples of the insertion device that we used along those 3 years. This one here is the original box. It was a bit like a phaco machine set up with tiny motors that drove the plungers that pushed the stent out. And then it became more and more refined until finally the most recent incarnation is a mechanical handheld system. So we did about 25 patients over those 3 to 4 years, and what we found was that the bleb that was formed was in many ways very much like a trabeculectomy bleb. It could still become encysted. There was a high need for needling with 5-fluorouracil, for example. We also found out quickly that you needed to have healthy conjunctiva for the stent to work. So if you tried to put it into scarred conjunctiva, it didn't work, which was not surprising in retrospect. Also, the bleb tended to be more posterior because the stent itself is 6 millimeters long, so it's delivering the aqueous humour to a position about 4 millimeters behind the limbus. So the bleb tended to be posterior. It did mean that we were able to put some of the stents infranasal. So with the trabeculectomy, we avoid doing inferior trabeculectomies because of the risks of infection. But in some of these patients, we did the stents infranasally, and touch wood, we didn't have any problems. So this is the long-term results. We published this data in Ophthalmology last year, and you'll see we followed patients out to 6 and 7 years, and you'll see that the average preoperative pressure was about 25, and that dropped down to the mid to low teens and stayed fairly stable over the following 6 years. But we did have I should have put in the Kaplan-Meier survival curve. So we did have a failure rate of about 1/3 to 1/2 over the 6 to 7 years. So if you like, the 50% survival is about 6 to 7 years. The other thing that is worth noting is that the numbers of drops that were used before the Zen was about, on average, 3 to 4, and that fell down to between 0 and 1 straight after the Zen. And you'll see the high rate of 5-FU injections in the first year or so, which also tended to fade off, so that by about 4 years, not many patients were requiring any further injections. So that was with, I better go back actually, that was with the original version of the microfistula, which we'd started making in the laboratory. It had an external diameter of 220 microns and an internal diameter of 120 microns. Now the commercial version, which was released about 3 to 4 years ago in Europe, has an internal diameter of 45 microns only and an external diameter of 90 microns. And the decision for that was made by the American Advisory Board. We were not involved in that. Also, there was a decision made to change the collagen to pig or porcine collagen because of fears to do with the mad cow disease and prions. Now, we've had the new version of the Zen, so what's called the Zen 45, in Australia for about 2 years. And in our department, we've set up a database system to track the results of those. And we've just had our first pass look at the data. So this graph, it's accurate, but I can't, there's a few things that I can't show you simply because we haven't fully analysed the data. So this is following out to 2 years, although most of the patients, about 144, have only gone to 12 months. But you will see a reasonable effectiveness in terms of pressure reduction, but note that the average preoperative pressure here is only about 21, 22 on average. So they're not as severe as the earlier patients. The earlier patients had all had failed trabeculectomies as part of their inclusion criterion, whereas these patients have not. And you'll see the handheld system now that we're using routinely. So just a couple of pictures of patients. It is useful in some difficult situations. For example, this patient had retinal detachment, only eye, very high scleral buccal, and you can see in the superior conjunctiva it's really made any sort of drainage surgery in that region impossible because of the very high buccal. But in that eye I was able to put an infranasal Zen in, which is still working a year later. Now this is comparing two techniques. You'll see our technique on the right-hand side and the technique that's currently promoted by Allergan on the left, where they promote the use of a hook to hold the eye, but it means you've then got both hands occupied. And if you like, just have a look at the sort of relative distortion, if you like, that you get. I think every surgeon has their own preference for their own technique and their own biases. My own bias is to use the technique on the right because whilst you have to put 3 stitches in the eye, there's a lot less distortion and there's more control in terms of using a gonio lens and having a free hand. Sometimes one needs to manipulate the conjunctiva in this area to make sure that the needle doesn't penetrate through as well while you're doing the surgery. So ideally we want to have the Zen going through the trabecular meshwork, that's the ideal position. And we also want to have about 1.5 to 2 millimetres in the anterior chamber, probably 1 to 1.5, about a 3 millimetre run through the sclera, perhaps 2 millimetres in the subconjunctival space. And on anterior segment OCT, ideally we want a straight sort of pass through the sclera rather than this wiggly sort of version that I've pinched off the internet. So I'm finishing. I realise I've gone a little bit over time. There's some simple ideas to try and improve the success rate. I do think that getting good control of the eye, having better fixation of the eye is quite important. I think our technique using the 3 stitches could be improved. It's a hassle to put those stitches in, but it's not a huge problem. But there must be a better way. If we could avoid viscoelastic, so at the moment we have to make a 1.5 or 1.2 millimetre incision to get the device in the eye. Initially we did not have to do that for various design reasons, and my thoughts are that some of the patients who did not have viscoelastics have actually done better. So there are some design improvements that could be made to the injection system. Also, if we could improve the gonioscopy so that we can more easily see where we're going. A bit like driving at night with the headlights, you do really want to see where you're going with surgery. And there's a few other points there that I won't go into. And just the comparison with trabeculectomy, it's pretty much equivalent in terms of the 2 to 3 year follow-up data, and our 6 to 7 year data is roughly equivalent to data that's come out of Moorfields looking at their trabeculectomy results. So on balance it seems roughly equivalent to trabeculectomy, but in saying that there's probably more attention required to attend to the blebs. I suspect there's more 5FU injections that are needed with the Zen. So I'm going to finish there, and lastly I just wanted to say and invite you all to come to several meetings in Australia if you fancy coming to Australia. We have RANZCO this year in Brisbane, I think it is, and also the World Ophthalmology Conference in Melbourne in 2022. But thank you very much.
Excuse me, can I have a questions, please?
Yeah, yes.
Yeah.
Yes.
First thing, why did you change the internal diameter from 120 to 45? Number 1.
So I'll answer your questions in sequence, if that's right.
Okay.
That's a very good question. I've asked that question myself. That was a decision made by the American Medical Advisory Panel. Are there any Americans here in the audience? No, so I can say what I think, can't I? As far as they're concerned, we're a bunch of kangaroos who don't know a whole lot of stuff, I think. So they were worried about hypotony, and having a larger diameter stent made them concerned, even though in our original trials we had no occurrence or risk of hypotony. And in fact, there seems to be more hypotony with the 45/90 version now. So that's a very good question. We had no part of that decision, unfortunately.
Second question is, what is the risk of getting this 45 bore gen getting blocked with a little bit of inflammation? Because if there is inflammation, the aqueous is getting more turbid,
Yes.
and it is likely to get closed sooner. So if there is no hypotony with 120 microns bore, why should you change it to 45?
Yeah, so in practice, I agree there's a concern there, and I would prefer to use the 220/120 micron stent myself if it was available to choose from. In practice though, with the 45 micron, I've used a number in uveitic patients. So far I haven't seen any block from inflammatory material. Now the numbers I've done have been relatively low, so it could still happen, that's for sure. Now I was also worried about pseudo-exfoliative material, because we have a lot of that in Australia. You probably have the same here. I was concerned that perhaps pseudo-exfoliative material might block the stent as well. and I haven't seen that happen yet. I have seen one patient with unusual white material blocking the stent, and I'm yet to find out what that is, and that patient I then had to do a trabeculectomy on, and they've done okay. But that's one out of about 200 to 300 in the last 2 years who's had a blockage. Now, I have had patients where the stent's gone in too far and it's been blocked by iris, but I would put that down to bad surgical technique, so I'm blaming myself for that. And there are issues with one point I put in the end of the talk is you don't have as much control over the axial positioning of the stent as you really should have. And that's one of the sort of issues in the learning curve of doing the Zen, is trying to gain control over that. And that's definitely an area that could be improved in terms of the introducer. So in terms of things blocking the stent that are not iris, for example, it's pretty rare. The main blockage of the stent is actually fibrosis in the bleb, and that's where there's such a high need for 5FU. Sorry, that's a very long-winded answer to your question. Yeah.
And there are reports there is more incidence of blebitis and more incidence of endophthalmitis with Jane implant. And what is the incidence of complications in your case?
So in my case, I've had no endophthalmitis. I have seen two cases of endophthalmitis done by other surgeons. In both those cases, the stent had perforated through the conjunctiva. I think one was at the time of surgery and one was later. Now, I've had 3 cases where the stent has perforated through the conjunctiva. And I think you have to treat them urgently and repair the conjunctival breach quite quickly. I think the problem with the Zen is that if it pokes through, then the bacteria have a direct route straight into the eye, and that's not modulated by any fibrous tissue or immune elements within a bleb structure. And I think that's possibly why the incidence of endophthalmitis has been perhaps more common. But I think a lot of that boils down to good bleb management. I haven't seen it in my own patients.
And what is the longest follow-up period for you, sir?
For me, it's now 10 years. So the patient that you saw at the very beginning, 2007, she died of heart disease 2 or 3 years later. Most of the other patients were done in 2009, 2010, so they're now followed out for 10 years. And half of them are doing very, very well.
Thank you. Thank you very much.
Thanks.
Thank you, Dr. Milind Morgan, for the wonderful talk and to give us an insight about the Zen. I would request all of you to please come on stage, the previous IC instructors, and Dr. Morgan to please come on stage. We'll have a group photograph.
मैं ले नहीं सकता, मैं किसी और भेज देता हूँ, मैं PPT करना।